So the topics I want to talk about today are listed here. A lot to cover in 45 minutes, and I'm going to try to highlight what you might be seeing when you take your ITE. So just first, a few questions in terms of fetal heart rate monitoring. So which statement about fetal heart rate patterns is most likely true? And if anyone wants to tell me what they think the answer is, let me know. Someone said D, I think. That is correct. So fetal tachycardia can result from a variety of reasons, but fetal hypoxia is one of those. So when you're doing fetal heart rate monitoring, looking at it, it's very much like reading an EKG. You need to be systematic. So you need to first look at what is your baseline heart rate, and then the variability, which we'll talk about what that means, and then periodic patterns, which means is there an acceleration, is there a deceleration, and then you need to pair those patterns with the uterine activity, specifically when you have decelerations. So normal baseline fetal heart rate is generally 120 to 160. Below 120 is fetal bradycardia. Below greater than 160 is considered fetal tachycardia. Now sometimes you will have a baby with a normal low baseline, so if you have a fetal heart rate, say in the 110 to 120 range, but with good variability, the obstetricians are probably not going to be concerned because that baby probably just has a lower baseline than most. So the question about tachycardia. So what can cause tachycardia? Well, it can be chronic fetal asphyxia due to inadequate uteroplacental perfusion. So that is why when obstetricians see tachycardia, they get concerned. But you need to realize there are other reasons. So if mom is septic or febrile, that can cause fetal tachycardia and may not be an indication to have to deliver the baby. If mom has thyrotoxicosis, and then a variety of drugs, including drugs that we give, can cause fetal tachycardia. Beta-mimetic drugs given for tocolytics, like if the obstetricians give terbutaline, you could see that. A large enough dose of ephedrine, you could see fetal tachycardia, and atropine, you could see fetal tachycardia, as that does easily cross the placenta, unlike a drug like glycopyrrolate. Now, fetal bradycardia, people tend to get even more concerned about this, and that is because in the majority of cases, fetal bradycardia is going to result from fetal asphyxia and fetal acidosis, which is a situation which means that baby is not doing well and needs to be delivered. There are other etiologies, including paracervical blocks. You can see local anesthetic toxicity in the fetus from that can cause fetal bradycardia. And then maternal beta blockers, and that's why we generally try to avoid pure beta blockers. We use a lot of labetalol in OB, but we generally try to avoid pure beta blockers because there have been case reports of C-sections done for fetal bradycardia due to maternal beta blocker therapy. And then congenital heart block is another reason that you could see fetal bradycardia. So once you've determined whether or not your heart rate is in the normal range, the next thing you do is you look at your variability. And what you're especially interested in is your beat-to-beat variability. And the reason for that is that if you have good variability, that is the most sensitive indicator of fetal well-being. You can also look at long-term variability, which is not beat-to-beat, but just over time you see kind of ups and downs, little accelerations. And this is just an example of normal fetal heart rate variability. And you get concerned primarily when the variability is decreased. If you see a tracing where it's almost straight across, your labor and delivery nurses are going to be very concerned about that baby with a loss or a very significantly decreased variability. There can be concern if you have exaggerated variability also, but that's much less common. So what's going to cause decreased beat-to-beat variability? Well, the reason they get concerned when they see a straight line fetal monitor is that decreased variability can result from fetal hypoxia and acidosis, just like fetal bradycardia. However, we need to understand that there can be fetal sleep cycles, so that's why they may do things like stimulation of the scalp if they're concerned about variability, because it just may be that you have a baby that's sleeping. But for us, what's especially important is to realize that many of the drugs that we give can decrease variability, like opioids, barbiturates, our volatile anesthetics, benzodiazepines, anticholinergics. They can all decrease variability. So we need to be aware of that so that if there's a change in variability and we've just given a drug, we need to make sure our obstetricians know that, and we need to understand if there's a concern about a tracing already, it's probably not the time to be giving drugs that could also affect that fetal heart tracing. In terms of periodic patterns, accelerations essentially refer to an increase in the fetal heart rate of at least 15 beats per minute when either the baby's moving or the mom is having uterine contractions. That is another sign of fetal well-being. But what we talk about more are the decelerations, early, variable, and late. So an early deceleration, essentially, its onset and its peak occur with the contraction. Essentially, we talk about early decelerations mirroring the uterine contractions. And with an early deceleration, you're not going to see the heart rate drop below about 100 beats per minute. A variable deceleration is exactly as described. It's variable. With each contraction, it can be different in terms of how far down the heart rate drops, how long it lasts, what the shape of the deceleration is. And oftentimes with variable decelerations, you will see the heart rate drop below 100. With a late deceleration, it's all about the timing. That deceleration is going to start after the peak of the contraction. Oftentimes, usually the heart rate does not drop a lot. It's going to stay above 100 beats per minute, but that is the most concerning type of deceleration because it's a sign of inadequate uteroplacental perfusion. So just examples of early decelerations there. You can see mirroring the contractions, just a little bit of a blip, and again, it's not dropping below 100 beats per minute. And then variable decelerations, as you can see, it looks a little bit different with each contraction. And then late decelerations. As you can see, that can be kind of subtle. You don't see a huge drop, but as you can definitely see, they're occurring after the peak of the contraction. So what do we know about early decelerations? And what I've seen about if they ever ask questions about fetal heart rate monitoring, they are not going to just ask, is this an early or late deceleration? They're going to be asking about the etiology, what's going on. So an early deceleration essentially results from, it's a vagal reflex from the head being compressed during a uterine contraction. It's not concerning. It doesn't require any sort of treatment. It's a normal vagal response. You have a baby that's got an intact neurosystem. Variable decelerations are also a vagal response. The vast majority of those are going to result from umbilical cord compression during the contraction. Late in labor, when the fetal head is descending down through the birth canal, you can sometimes see variable decelerations resulting from that intense dural stimulation from the fetal head compression, causing that vagal response that causes the variable deceleration. So variable decelerations may be concerning. If they're recurrent, if they're having them with every contraction, they're very deep, they drop down very low, and they take a long time to return to baseline. That may be concerning because that baby's ultimately going to lose its ability to compensate for that. Now, if they're just short decelerations, they return to baseline quickly, they're not really deep, then generally your obstetrician isn't going to be concerned about those variable decelerations. And then late decelerations, as I said, the etiology of a late deceleration is always inadequate uteroplacental perfusion. So that is why even if it's only dropping down 10 beats per minute, we are concerned about the deceleration. And this is where you want to first start in utero resuscitation. So you'll see the nurses will put oxygen on, get the patient on her side if she has been lying flat on her back, giving her fluid. If you've got a patient with an epidural and who's having late decelerations, you need to make sure you check the blood pressure and that you don't have some hypotension that needs to be treated and that is causing that late deceleration. And then finally, looking at all those different decelerations and variability, putting all that together, you then categorize your tracing into one of three categories. So category 1 tracing, that's what you want. So normal heart rate tracing, strongly predictive that this is a normal baby with normal acid-base status. Category 2 is sort of indeterminate. It's when you're maybe having some variable decelerations or you have some small decrease in variability, but it's not like a flat tracing. So in this case, you really can't predict if that baby is doing well or not. And so if you have a category 2 tracing for a period of time and it goes back to category 1, that's fine. But if you have a tracing that continues to be category 2 for a very long period of time, it may prompt an obstetrician to want to deliver that baby. And then category 3 is the one you don't want to hear about. Category 3, that's abnormal. It is predictive that you have abnormal fetal acid-base status. You have a baby that's getting acidotic and hypoxic. And in this case, you're going to need to do something, see if in utero resuscitation works. If not, this is the type of tracing where the obstetrician is going to say we need to be going back now for a cesarean delivery. Now, we're going to move on to labor analgesia. We could spend an hour talking about labor analgesia and all the different ways to do it. We're not going to do that. I'm just going to hit the real basics for this. So you have a woman in active labor at 5 centimeters dilation. She's having pain with each contraction. Which of the following is most likely responsible for her pain? Anyone? So it's going to actually be, it's the passive stretching of the cervix is what causes that labor pain. A lot of people think it's that contraction of the uterine fundus. It's really not. It's that dilation and stretching of the cervix is what's causing that labor pain. So in terms of taking care of labor analgesia, I think you need to understand the pain physiology in order to be able to do a good job of managing someone's labor pain. So the first stage of labor is a visceral pain. That first stage of labor, it's a visceral pain, as I said, that's caused by that cervical dilation and the distension of that lower uterine segment that occurs as the patient is laboring. The pain pathways for the uterus are visceral afferents that accompany the T10 to L1 sympathetic nerves. So in early labor, to get a patient comfortable, if you're doing an epidural, you need to block T10 to L1 to get good first stage analgesia. Now, during the second stage of labor and also during transition, the late first stage of labor, in addition to that visceral pain from the stretching of the uterus, you also have a component of somatic pain that results from the stretching of the perineum as that fetal head descends down through the birth canal. So that somatic pain that you have later in labor, that is innervated via somatic nerve fibers that make up the pudendal nerve, which is derived from the S2 to S4 nerve root. So that's why when someone has progressed in labor and they're complaining of perineal pain, you need to be blocking those sacral nerve roots at that point in labor, in addition to having that T10 to L1 block that's taking care of that visceral pain from the distension of the lower uterine segment and dilation of the cervix. So, which of the following techniques is least likely to provide adequate analgesia for the first stage of labor? And I really just gave you the answer. So what is it? It's going to be D, pudendal nerve block. That's going to take care of that somatic pain. But in the first stage of labor, when you're just having that visceral pain, just doing a pudendal nerve block is not going to do anything for that patient. So, as I said, I don't have a lot of time to talk about labor analgesia. We could sit and talk about it for 2 hours, and we'll do that when you're on labor and delivery. But what I did is I put together this little table because I have seen questions where essentially they are asking you, they'll describe the patient, you figure out how far dilated she is, where she is in the labor, and they're just going to ask you what technique will provide adequate analgesia to this patient, or what technique won't provide adequate analgesia. So this nice little table helps you out. So epidural local anesthetics, that's going to take care of everything. Part of why we do epidurals. First stage of labor, both early and late. Second stage. Epidural opioids actually can be effective early in labor, but they're not going to provide effective analgesia later in labor and during the second stage. A paracervical block does take care of the first stage of labor pain, but we generally don't do it because because it can cause fetal bradycardia, as I mentioned when we were talking about fetal tracings. A pudendal block is going to take care of that somatic pain, so it can take care of that component of the second stage of labor. A lumbar sympathetic block can take care of the first stage of labor, and just like an epidural, a combined spinal epidural can take care of all stages of labor. So that just is a real brief summary of labor analgesia in terms of what techniques that we do can provide adequate analgesia. So, but there are adverse effects when we do things like epidurals. And so if in this question, if you're comparing it to IV opioids, epidural labor analgesia is most likely associated with which of the following? Right, an increased incidence of maternal fever. Some people think C-section, it doesn't really. Many years ago, people did say that, you get an epidural, you're more likely to get a C-section. The epidural itself, there's no causal relationship there. Actually, probably not a significant effect on duration of labor other than slightly prolonging second stage. And there are data that women with epidurals oftentimes are more likely to get oxytocin augmentation. So what are the potential adverse effects? So you're doing an epidural, you cause a sympathectomy, you can see hypotension, and that's why you need to be aware of that. You need to treat it so you're not getting called in that you're causing that category 3 tracing that we just talked about. It can prolong the second stage of labor by about 15 minutes. The key, though, is that there clearly are data that you see increases in maternal temperature with a labor epidural. Still research going on as to what the etiology of that is, but we know it's a phenomenon that does occur. And then there may be an increased rate in instrumental delivery. The studies have shown women with epidurals are more likely to have an instrumental delivery. But what we don't know is there does not seem to be a causal relationship. If someone's been pushing and they're getting tired and they have an epidural in, the obstetrician is probably more likely to think about putting a vacuum or forceps on than if they have no analgesia. But there does seem to be a correlation there. I just want to mention this in case it shows up. So paracervical block, as I said, it's generally not performed because of that risk of fetal bradycardia. And also, even for the from the maternal side, if you're looking at comparison of maternal serum levels with local anesthetic, it's the highest in terms of serum levels that you will achieve due to where you're injecting and the volumes that you're injecting. So that's 2 reasons why we don't ever do it, but as a trick question, I might ask you, can it give you labor pain relief? It can during the first stage. Now, next, anesthesia for C-section. We could probably spend at least 30 minutes just talking about anesthesia for C-section, but we don't have time for that. So a brief overview. For those that have probably done OB, a lot of this is basic, but there's some of you that are going to be taking this without having done OB, so this will help you. So regional anesthesia is generally our preferred technique in most situations in order to avoid the risks associated with general anesthesia in pregnant women. We know that there's a higher risk of difficult intubation in OB patients, also risk for aspiration. To get adequate anesthesia with regional anesthetic, you need at least a T4 to T6 level. One of the times that you would not do regional or neuraxial anesthesia, obviously a coagulopathic patient, a patient who's septic or in shock for whatever reason, be it hemorrhagic shock, and of course if the patient refuses, you are not going to be sticking a needle in someone's back. But in most of our patients we'll be doing regional anesthesia, and then we have to decide which one are we going to use. So epidural anesthesia is preferred when you have a anticipated difficult airway. The reason being, if you put an epidural in and you dose that catheter, you know it's working, you know you can redose it if the surgery ends up being longer than you anticipated. Whereas like a single shot spinal, if they have trouble, there's a possibility the spinal wears off, you've got a difficult airway in the middle of surgery, you probably don't want to have to then be putting the patient off to sleep. For same reasons if you think it's going to be a prolonged surgery. Clearly, a patient who's been in labor with an epidural that's working, your preferred choice is going to be to dose that epidural. And there are a few other situations where you may specifically want to raise your anesthetic level slowly so that you don't get a rapid onset of sympathectomy and decrease in SVR and maternal hypotension. And that would be in women with significant cardiac disease. And occasionally, if you have a compromised fetus that you think any little drop in blood pressure that baby may not tolerate, you may want to use an epidural rather than a spinal where you get a more rapid onset. So a patient who's receiving epidural labor analgesia is taken to the OR for an emergency C-section for fetal bradycardia. Which epidural local anesthetic do you want to use to dose her epidural? And we talked a little bit about this the other day too. It would be 3% chlorprocaine because if you have fetal bradycardia, you're concerned that you have an acidotic fetus. You don't have the issue of ion trapping. And in addition, you get the most rapid onset, so you're most likely to get a level in time before the surgeons are ready to start. But if you do epidural chlorprocaine, which statement about its use is most likely? So the answer would actually be C, because it is metabolized by plasmacholinesterase. So if you have a woman that's homozygous for atypical plasmacholinesterase, you can see an increased level of that local anesthetic. In terms of epidural morphine, it actually decreases the efficacy. It's clearly not contraindicated. It's indicated with late fetal heart rate decelerations, since that baby's going to be acidotic, and it does not have a higher systemic toxicity compared to ropivacaine. Now, if you're going to use an epidural in terms of dosing, you need a T4 to T6 level. In a non-emergent situation, usually our preference is to use lidocaine. We already talked about chlorprocaine. Additives, they may ask about this. So if you add epinephrine to your epidural, it will increase the density of your block and it will prolong your duration. If you add sodium bicarbonate, it will speed the onset of your block. Now, spinal anesthesia for C-section is going to be preferred in any situation where you need a more rapid onset. It's also going to provide a denser block than epidurals. And you do want to, though, as I mentioned, avoid it in situations where you anticipate a difficult airway or prolonged surgery, because with a single shot spinal, if it wears off, it wears off. Nothing you can do but convert to general. With a combined spinal epidural, you do have an epidural catheter in place, but occasionally, not often, but rarely, that epidural catheter can fail you. You've not dosed it yet, and so you still might be in a situation of having to convert to general if you find out your catheter is not working. This was one of the key words I was asked to address, not specific to OB, but just spinal anesthesia. So what are the physiologic effects of spinal? So cardiovascular-wise, you're going to see a decrease in stroke volume. Your cardiac output is going to generally be maintained or slightly decreased, but you will definitely see a decrease in systemic vascular resistance. In terms of respiratory effects, in healthy, normal weight patients, it's going to be effective minimally. You'll see a small decrease in FVC and a small decrease in your peak expiratory flow rate. But if you have obese women, you can see as much as a 25% decrease in your vital capacity with a spinal in an obese patient. Combined spinal epidural, as I said, it does provide the benefits of a spinal, which is a bit denser block, more rapid onset, with the versatility of an epidural. But as I said, sometimes that epidural catheter may not work. You haven't dosed it, so you don't know 100% that it will work. So in those cases where you don't want to have to convert to general in the middle of the case, I probably wouldn't do a CSE. General anesthesia for C-section is going to be your anesthetic of a choice. Especially in cases of, fetal bradycardia, you need to do a stat C-section. Mom does not have an epidural catheter in place. The fastest way to get that baby delivered that's in extremis is to do a general anesthetic. Also, if you have a significantly hemorrhaging mother where she will not tolerate the sympathetic block of an epidural or spinal, general would be your drug of your anesthetic of choice. And of course, as I mentioned, your concerns are related to intubation, to aspiration. In terms of management of general anesthesia, you need to make sure that you give a non-particulate antacid, left uterine displacement, adequate pre-oxygenation, and rapid sequence induction are the things to keep in mind with that. This has been a question before, how to handle a failed intubation after induction of general anesthesia for an emergent C-section. What are you going to do? So if it's an emergency, you are not going to awaken mom, unless it's actually in extremis. You really need to get that baby delivered. Generally, if you can easily mask ventilate, what would be the traditional teaching is if you can easily mask ventilate and you have a baby in extremis, apply cricoid pressure, mask ventilate, get that baby out quickly, and then you secure the airway elsewhere. You don't want to maintain mass ventilation with cricoid throughout the surgery, but it is valid to do that until baby's delivered if you have a baby in extremis. If you can't mass ventilate, you need to ventilate. That's the most important thing, even more important than securing the airway. So place an LMA and then once you can ventilate, try to get a better airway, or if you can't do something else, you can also keep the LMA in with cricoid pressure applied after the LMA has been placed. And transtracheal jet ventilation in an emergency can be used in a parturium. So I sort of just gone over this. So if it's an emergency C-section, you can easily mass ventilate. Keep mass ventilating with cricoid till the baby's delivered, then secure your airway. If it's a non-emergent C-section, though, if the question were non-emergent and you cannot get the mother intubated, the recommendation would be to actually awaken the mother and then either proceed with another way to secure the airway or to consider doing regional anesthesia if the patient will allow that. In terms of maintaining general anesthesia during C-section, before delivery, 50-50 nitrous oxygen. As long as mom is oxygenating normally, increasing your FiO2 beyond 50% is not going to increase oxygen delivery to the baby, and anywhere from half to 1 mac of volatile agent. After delivery, you want to decrease your volatile agent. You can now start giving opioids. We generally avoid opioids until baby's delivered, and then you can up your nitrous oxide also. This has been a question before, so if you're using volatile anesthetics, how is pregnancy going to affect uptake of volatile anesthetics? Well, the rate of rise of your alveolar concentration is going to be increased due to the fact that you have both an increase in minute ventilation and a decrease in FRC. Now, you do also have increased cardiac output in pregnancy, and that would decrease the uptake, but the combination of the increased minute ventilation, the decreased FRC, is greater than that. So in pregnancy, you will have an increased uptake. So if you were to do an inhalational induction, which you're generally not going to do in a pregnant full stomach patient, but they might theoretically ask you that, you will have a more rapid inhalational induction in pregnancy. What about effects of general anesthesia on the infant? So nitrous oxide readily crosses the placenta. Fetal levels are going to equilibrate with maternal levels after prolonged exposure, but generally babies delivered within just a few minutes. Generally, until baby's delivered, keep the concentration at 50%, no higher. You're going to see less depressant effect from nitrous oxide if they can get the baby delivered within 15 minutes after induction of your general anesthetic. Your halogenated agents also easily cross the placenta and rapidly equilibrate with fetal tissue. So if you don't have a rapid delivery, again, if it takes a long time to get the baby delivered, you can see some neonatal depression from those volatile agents. Just be aware the FDA does have a statement out there that prolonged exposure, so that may be, if you're doing a long surgery, not an emergency C-section, they do say that prolonged exposure might affect neurocognitive development, just like there's that concern in babies also. There's no real evidence to support that, but the FDA, that statement is out there. So patients receiving general anesthesia with death-throwing and nitrous oxide for emergency C-section, which statement about the effects of general anesthesia on uterine tone is most likely true? Anyone know? It's actually going to be C, that desflurane actually has somewhat lesser effect on uterine tone than sevoflurane, but essentially all your halogenated volatile agents are going to have an effect on uterine tone. So they decrease the uterine tone, and it's a dose response curve sort of thing. So the higher your volatile agent, the more effect on uterine tone. If you maintain your volatile agent at a half MAC or less in a normal uterus, you should see normal contraction. Now, if you have someone with choreo or some reason that the uterus is not normal, then even at lower MACs, you may have an effect of that volatile agent on uterine tone. But between 1 to 2 MAC, you'll still see some response to oxytocin if you give it. Once you get beyond 2 MACs, you can give all the oxytocin in the world and there will be no responsiveness to it. So dose-dependent decreases uterine tone. Ketamine, on the other hand, in large dosage, which would be a large induction dose of more than 1 milligram per kilogram, can actually increase uterine tone. So if you're in a situation where you already are concerned about uterine hypertonus, like an abruption, or they tell you that she's hypertonic, that's not the time to be using ketamine for your induction agent. So a patient's taken to the OR for manual extraction of a retained placenta. Her blood loss has been 500 cc's. Vital signs are stable. Her epidural has been dosed to get a T10 level. And the obstetrician is attempting to get that placenta out, and they ask you for uterine relaxation. So which is the best technique to achieve that uterine relaxation he's asking for? What was that? A, yes, nitroglycerin. So let's go over a little bit about methods for uterine relaxation. So nitroglycerin, potent, smooth muscle relaxant. The uterus is a smooth muscle. So it is the preferred drug when you need rapid onset uterine relaxation. It's because it's rapid onset, it's also short duration. Because in most cases when they want uterine relaxation, it's for something like to take out a retained placenta or a uterine inversion. And so as soon as they get that issue taken care of, now they want the uterus to contract down. So you don't want to give something like magnesium that's going to last for a long time. You can see some significant, you can see some hypotension, but you don't generally see much, and it's very short acting. So I don't worry about giving a bolus of nitroglycerin 50 to 100 mics and causing significant maternal hypotension. Volatile agents, your volatile agents can also, as we said, give a dose-related relaxation. So you'll see about a 50% decrease in the uterine tone with approximately 1 MAC. And so I've had cases rarely where, for the nitroglycerin was not adequate. You could, patients at full stomach, so you'd have to induce, intubate, and then start the volatile agent. And if you're trying to get uterine relaxation, you need to bump up your concentration and hyperventilate to get that level up high enough to get the relaxation that your obstetrician needs. Now, nonobstetric surgery during pregnancy. So which of the following recommendations best reflects the ASA statement on nonobstetric surgery during pregnancy? So is it if the baby's not viable, you don't need to look at fetal heart rate at all? Or you need continuous heart rate if the baby's viable? Should perform surgery if you can time it in the second trimester, or you should avoid midazolam because it's teratogenic? So the answer is actually going to be C, that actually the best, if you can, usually you can't time non-obstetric surgery during pregnancy, but if you can, second trimester is the best time. So what do we know about non-obstetric surgery during pregnancy? So you still have to worry about the physiologic changes of pregnancy. Just because she's in the main OR instead of on labor and delivery, you still have to think about the things like uterine placental perfusion, left uterine displacement, full stomach, etc. What about the effects of those drugs that we're giving on the baby? We need to make sure we maintain the uterine placental perfusion, fetal oxygenation. And another concern, especially with abdominal and pelvic surgeries, is trying to prevent premature labor. So what do we know about teratogenicity of anesthetic drugs? First of all, in terms of benzodiazepines, many years ago there were some poorly done studies that showed an association between the chronic use of Valium, like for anxiety or whatever, not just for anxiolysis during a procedure, and fetal anomalies. As a result, the FDA, although people still talk about classifications of drugs in pregnancy, the FDA has gotten rid of them. But if you hear someone talk about Class D, which means there's evidence of harm during pregnancy, they decided to put all benzodiazepines as Class D drugs because of that. But there's not been any reports of any problems with like single small doses of a benzodiazepine for anxiolysis for a procedure. Nitrous oxide has been controversial. Again, earlier there were some poor data suggesting, that there may be increased fetal loss, miscarriages, but that data wasn't so good. Still, probably most people, if they can avoid nitrous oxide, will avoid it in a pregnant woman. Essentially, the bottom line is, in terms of your anesthetic technique for non-obstetric surgery, there's no data to suggest that any specific technique or any specific drug gives you better or worse fetal outcome of that pregnancy. Oftentimes, if it's amenable to do the procedure under regional, you would prefer to do it. Mostly for maternal effects, that you avoid those increased risks of general anesthesia, but also just intuitively, if you can minimize drug exposures to the baby, you probably want to do that. Because, again, all these drugs, none of them have been tested in pregnancy. We just know from long-term use that there doesn't seem to be any problems, doesn't seem to affect outcomes, but it makes sense to use as, little drugs as you can. So, by doing regional, you just use a local anesthetic in the area of the surgery. Makes sense to do that. Things to keep in mind, after 20 weeks, you can start to see some aorocaval compression, so left uterine displacement after 20 weeks gestation. You want to avoid maternal hypercapnia if you have someone under general anesthesia or sedation, because that can lead to fetal acidosis. But, sometimes in the main OR, we tend to actually hyperventilate our patients. With a pregnant woman, you really also want to avoid hyperventilation, because if you hyperventilate mom, you make her alkalotic. Maternal alkalosis can lead to uterine artery vasoconstriction, so that actually can adversely affect uterine placental perfusion also. Also need to be aware of if you are going to be doing intraoperative monitoring. Our obstetricians don't do that very often anymore, but there are some institutions where they do frequently, if they have a viable fetus, do intraoperative fetal monitoring while the patient's anesthetized. Remember what your drugs are going to do. So the opioids, your induction agents, your inhalational agents, they are going to decrease or even eliminate your beat-to-beat variability. So the person looking at the fetal monitor needs to understand, you need to let them know that you're not going to be able to comment on variability. So all you can really do if you're doing fetal heart rate monitoring in a patient under general anesthesia is look at your baseline fetal heart rate, that it's within a normal range, and that you're not having or that you are having decelerations. In terms of preterm labor, the incidence of preterm delivery is increased in pregnant women who undergo surgery. Not necessarily the anesthesia, not necessarily the surgery. It may be the underlying problem that's causing this patient to have surgery. But we know that the greatest risk of developing preterm labor in association with non-obstetric surgery is during the third trimester and when you have surgery in the pelvis or abdomen. So that is why the second trimester is really the preferred time to do non-obstetric surgery, because you're not worried about organogenesis in the first trimester. So that's why you'd rather not do it in the first trimester. Like I said, seems like our drugs don't affect baby, but there's not a lot of data. So if you can avoid it during that time of organogenesis, then you don't do surgery during that time. And if it's in the third trimester, you're much more likely to precipitate preterm labor. So that is why the second trimester is the ideal time to do non-obstetric surgery. So anesthesia for cerclage was another, term that we were supposed to address. So I'm not sure what the question would have been. Things to remember, it's generally done with a neuraxial anesthetic. You do need like a T10 to S4 level because they're working down around the perineum, so you need to have the perineum anesthetized. However, the cervix, uterus and cervix, we talked about, innervation of that is T10 to L1. So when they're up there actually putting the stitch into the cervix, you also need to have the T10 through L1 coverage also. So you need a block from T10 down to S4. And we do, because it is early in pregnancy, we do generally avoid anxiolytic and sedative drugs if we can, just because we like to minimize drug exposure to baby, even though there's no good evidence that any of our drugs cause problems. But if you can't avoid it, we try to avoid anxiolytic drugs in those patients. This was another key word I was asked to address, which is meconium-stained amniotic fluid. I believe this relates to neonatal resuscitation. So what are the teachings right now about meconium-stained amniotic fluid? Well, essentially, they no longer, in terms of neonatal resuscitation courses, even in non-vigorous infants, they no longer recommend routine suctioning, routine intubation and suctioning. Essentially, if you have a vigorous infant, if you have meconium and the baby comes out vigorous crying, you just do your routine, dry baby off, stimulate baby. You don't do anything special. If you have a non-vigorous infant, you pretty much follow those same resuscitation guidelines as an infant without meconium. But if you do have a baby in which the airway actually seems to be obstructed from meconium, then you would intubate and suction in that situation. In the past, the teaching was that if the baby wasn't vigorous, you always intubated and suctioned. But now they're just saying only if it appears to be some obstruction of the airway. Otherwise, they do not recommend intubation and suction before beginning mass ventilation for that non-vigorous infant in the setting of meconium. So those are the most recent teachings on that. This has been another, key word, which is neonatal myasthenia gravis. So things to understand is that, in terms of myasthenia gravis in the mother, results from antibodies to the acetylcholine receptor. Those antibodies can and do cross the placenta. So about 16% of babies whose moms have myasthenia gravis, as a result of those antibodies crossing the placenta, will present with neonatal myasthenia gravis. And that means that baby within 4 days of delivery is going to present with symptoms like feeding problems, hypotonia, respiratory difficulty. Essentially, it will resolve on its own over about a month as those antibodies are metabolized. But until those antibodies are gone, that baby may require treatment with anticholinesterase therapy.